Welcome, everyone. Hello. So delighted that you have chosen the Compliance versus Adherence module from the Hartford Institute. Hi, I'm Elaine Gould. You see me here all dressed up for my niece's wedding a few years ago, but that's more or less what I look like. A little bit about this module. This is an online module of the Consortium of New York Geriatric Education Centers, and it was developed by the Hartford Institute for Geriatric Nursing at NYU and its College of Nursing. You will see these three websites there. One is for the GEC, and the other two are for the Hartford Institute. And we hope that you will explore them after this module. The CNYGEC is actually a consortium of 4 academic partners, and we are all committed to training a wide range of healthcare and human service professionals and interdisciplinary faculty throughout New York State. And you'll see the partners there. There's Mount Sinai, there's NYU, there's Columbia, and something that you may be unfamiliar with called the GREC, which is Geriatric Research Education and Clinical Center, which is part of the VA system. And we are delighted to be funded for many, many years by HRSA, the U.S. Department of Health and Human Services. The objectives of this module. We hope that at the end of this module you will be able to understand the components of care planning for older adults and to differentiate between compliance and adherence for older adults, and understand an acronym called AIDS, which is about, it's an adherence model which applies to older adults. So let's first look at what all of this is all about. The title of this project, of this module, is Compliance versus Adherence and Consequences for Older Adults. And it's important that we look at these two words because words have meaning, and we use them not necessarily correctly, and they create certain atmospheres for us. So there are a lot of changing relationships of both providers and patients going on in the healthcare arena at the moment. We have a tremendous increase in incidence of chronic diseases. We have an increase in the comorbidities and the complexity of the comorbidities. As you know, there's a tremendous movement to control healthcare costs. And we have an increase in team approach because of all of the complexity that's going on. And we have a greater responsibility of care that now seems to be being placed on patients and their families. So in order to get better outcomes in illness management, we really need to create some behavior change. And a patient's role in care often requires this change in behavior. You have to change what patients do. And we also have to change what providers do as well. And this changing behavior works best in the context of a care plan. We need to know what we're doing and why. So what is a care plan? Well, it's a document outlining a plan of care for a patient for a specific period of time. It also serves as a guide for all who are involved in the care of a patient to provide appropriate treatment and to try to ensure optimal outcomes. So there are a whole slew of different kinds of care plans. What are some of the variations? Well, one is that it can be discipline specific. It can be specific around what a physician or a nurse or a social worker or a pharmacist is supposed to do for a patient, and that's perfectly fine. However, it tends to encourage providers to work in silos, which is ultimately not beneficial for older adults. So we look to care plans that are interdisciplinary and bring all of these providers together, looking and focusing on the patient and what their particular roles are in order to help the patient. Care plans can also be specific to one health issue. We may have a plan about how to control someone's diabetes, how to control their congestive heart failure. And that's fine too, but unfortunately it's not the whole picture about what the patient is dealing with in terms of their total health. And so again, we look for better care plans would be ones that are more comprehensive and that deal with multiple health issues. There are also care plans that actually delineate protocols. If you see this, you do that. If you see that, you do something else. Those are fine too, but again, they're limited in their focus. And so what we're really looking for are care plans that are patient-centered. And in fact, a new term that we're seeing now is care plans that actually create contracts with a patient so that everyone is on the same page. And we'll talk more about this as we move forward. So let's first look at the components of care plans. You have to have some baseline data. You have to know what's going on at the moment the care plan is to begin. And so you need to conduct a comprehensive assessment. And after you do that, the assessment will yield really a delineation of a problem list, the diagnoses, the psychosocial strengths, and issues that affect conditions and a person's well-being. And once you have the problem list, then you need to define the level of each problem. How serious is this problem? Will this problem get better? Can we keep this problem from getting worse or developing complications? What can we do to optimize the quality of life and comfort and dignity until the end if everyone feels that we are close to the end of a patient's life? And after that, we create goals for each of these problems, and we delineate interventions and approaches with, and this is the important part, responsibility and a timetable, which includes not only the provider's timetables and responsibilities, but patients and family members as well. And then a very crucial part to this care plan is to reevaluate at the end of the time period to see if the patient's status has changed. And of course, if a patient's status changes abruptly in the middle of the time period, then the whole thing starts all over again right away. But care plans need to have intervals and time periods, and then they can be taken seriously. Because many times, and in many places, providers think that care plans are just more paperwork, but they really are not. If they're used creatively and purposefully, they really can be useful to try to optimize outcomes. So now let's look at this whole notion of compliance and adherence. Once you have a care plan, the traditional view is that you want compliance to that plan. And so what is compliance? Well, it implies a one-way process. Clinicians dictate the treatment regimen, and the patients must comply. However, and we've been doing that since healthcare began, but now it seems, and I would probably say thanks to the baby boomers, there's been a different viewpoint that is becoming more popular, and is changing the vocabulary, and it's changing to the vocabulary to the notion of adherence, which is much more of a collaborative process. It's defined as the extent to which a person's behavior, taking a medication, following a diet, or executing a lifestyle changes, corresponds with agreed recommendations from a healthcare provider. Adherence emphasizes the patient's and caregiver or provider's role as a partner in the treatment and the decision-making process. This is very new. You will hear people say that patients are non-compliant, but a gentler way to look at all of this is perhaps saying that they're non-adherent, and we will look for reasons why in just a minute. But let's look a little more carefully at the notion of compliance and adherence. Compliance is basically a medical model, and adherence is a behavioral model. In compliance, the practitioner is the center of the universe, and information is given by the practitioner, and in fact, the practitioner wants to save the patient, or certainly cure the patient along the way. And they will dictate behavior, the gold standard of care, in order to achieve that. But the problem is it gets us into a win-lose orientation. It augments the notions of confrontation and kind of fighting over what's supposed to happen. It's a very authoritarian viewpoint of a parent and a child. The physician says, or the provider says what's right, and the patient or the child is supposed to do it. No questions asked. And so we persuade and we even manipulate if we care to, And we look at resistance as being bad. The patient is non-compliant. They're not being cooperative. They're not doing as they're told. And that is really problematic, and we're going to talk a little more about that in a minute. And so we argue, and we get power struggles, in fact, in this process. And respect is expected, and providers get insulted when patients don't give them the proper respect that they think is due them. So that's the compliance model. It's been around a long time. It's still around, but we're finding that it's less than satisfactory. And if we change our viewpoint a little to a behavioral model and to one of adherence, we see a substantial difference in focus. In the adherence model, it's patient-centered. It's not practitioner-centered. The patient is the center of what's going on, because ultimately it's the patient that we want to help. And in that environment, information is exchanged. The patient tells the provider things, and lo and behold, the provider is supposed to actually listen. And in fact, the provider can tell the patient things, and it's expected that the patient will in fact listen as well. And it's the process where the patient takes responsibility for their own health care. So in fact, they are trying to save themselves, and they have a commitment to that betterment. In this situation, we negotiate behavior, because behavior is only as good as the patient is willing to commit to and is capable of doing. So it becomes a win-win orientation instead. It's a collaborative process of equals. And that's a difficult concept, because many healthcare providers have spent a lot of time and a lot of money and a lot of education to gain an expertise, and so they do not think that they are on equal terms with the patients. However, in fact, they are, because this is not about the providers, this is about the patients, and what the patients want and what the patients will do. So it's important that we assess the readiness and understanding and the acceptance that a patient will have to participate in his or her health care. And that means that resistance, non-adherence, is in fact a source of information. It's not just bad behavior. There's a reason that people resist, and we need to find out what it is. The most important question you can ask is why? Why are you having trouble doing this? Why don't you agree with this? Why don't you want to do it? And it's amazing the answers that you will get if you ask that question. And so we delineate. It's also important, rather than arguing with the patients and trying to dominate them, we give them the autonomy to create their own lifestyle and accept their own level of risk. But they need to know the consequences of their actions. If we as providers think that their actions are unhealthy or dangerous, we need to make sure that they understand the consequences. If they still want to continue, for instance, continue to smoke, it is their choice and their prerogative, but they have to understand what the consequences are of their choosing that course of action. And so respect actually gets earned. Everybody earns the respect of the other party in this situation, because there is a mutual collaboration that's going on. So there's a big difference between adherence and compliance. And when you use the word compliance, you are setting up an atmosphere. And if you use the word adherence, you're setting up a completely different atmosphere, one that is more patient-centered. And patient-centered is a word that you're hearing a lot these days in healthcare. And adherence is a notion that helps us bring that focus into view. So before we move off of this slide, and I know I've been on it a long time here, I want to give you a case example of the difference between compliance and adherence. And it's a personal one, and I will let you in on a secret. This is a story about myself and my dentist and my hygienist. And the secret is that I do not floss my teeth. Now, you are allowed to laugh because it's perfectly okay, because it's sort of a funny story. For 20 years, I have been going to this dentist and hygienist, and I love them both dearly. And I get my teeth cleaned, and the hygienist says, she gives me that little take-home package. And in that package, she holds up the flossing container, and she plops it in the bag, and she says, you know, flossing is the most important thing you can do. And I said, I know, but I really don't floss. I hate to floss. And she said, oh, it's the absolute gold standard. You really should do it. She puts it in the bag, and I say, okay, I'll try to be good. I go home, and I promptly put that flossing container under my sink. For 20 years, I did that. And when I finally decided to clean out under my sink, I found miles and miles of unused floss. And I said, okay, this is kind of silly. I'm teaching about compliance and adherence, and maybe we can get somewhere with my hygienist. So the next time I go back and she waves around the flossing container, and I say, you know, I'm not going to floss, so don't bother putting it in the bag. And she says, oh, it's the most important thing you can do. You really should try. And she plops it in the bag. And after she leaves the room, I take it out of the bag and I put it back on the counter. And I go home feeling very triumphant. I come back a few months later and she says to me, I see that you didn't take the floss I put in your bag. And I said, yes, because I'm not going to floss. So we are now in this win-lose war of wits. And in the process, I say, look, if the goal is to get to Elaine to floss, you lose, because I'm in total control of my behavior and I'm simply not going to do it. If the goal was better oral health for Elaine, I'm happy with that goal. How else can we reach that goal other than flossing? So she looks at me and she says, well, you could come more often and pay more money and I can clean your teeth more often, or you can use some mouthwash, or you can use these preset flosses that have the string already attached, and maybe that would be better, or I can give you these little picks, and on and on. She brainstorms about a whole host of other things that would do it. Through all of this, as you can see, did she ever ask me in 20 years, did anyone ever ask me why I don't floss? Because in fact, it might have led to a very easy solution. Did she ever give me a plan that we might agree to for a month or two, where she'd say, do me a favor and floss and come back in a month and let me know? Well, I might have even tried that to be nice to her because I really like her. But what I was doing here was conciliatory resistance. And we'll talk more about that. I was saying, yes, I would try to be good, and I go home and I'm not good. I'm not good according to those standards. So we were still at a win-lose situation, and she never quite got the notion that if I was to be compliant, I really needed to be adherent, in fact, and that we needed to have a plan that we could both agree to. I was not going to do the gold standard, but if she had gone to a plan B, which was something else, which would have 80% effectiveness, she would have been much better off, because right now, even though she was telling me the gold standard, if I don't do the gold standard, it has zero efficacy, and we might have gotten to a place of 80% efficacy if we had joined together. So I'm going to continue now, and I will reference this story as we go along. So, all right, we have to try to assess adherence here. We need to explore the accuracy of a patient's self-report through open-ended questions about exact patterns of behavior, particularly, let's say, about taking medications or doing a lifestyle change. If you say, did you take all your medicines this month? Somebody would probably say yes. If you say, gee, how many times did you forget to take your medicines this month? Somebody would probably, that same person would give you a different answer. So it depends on how you ask the questions, what kind of information you get. There are also obviously objective measures like blood levels and all kinds of chemistry levels. And what's interesting, we have found that there's a national rate of about 50% adherence for all populations, whether it's older adults, children, grown-ups, whomever. And so that leads us to the question of, well, what level of adherence is enough? If she got me to floss once a week, would that actually be enough? And what was fascinating about all of that was every year that went by that I didn't get gum disease without flossing, I won. It was supportive evidence that I never needed to floss in the first place because there was no bad consequence that was happening to me. And so it brings up the other point of trying to understand that one size does not fit all in terms of care plans and what you do. But you need to assess someone's sort of ability to adhere. And there are a lot of reasons for non-adherence. People don't usually get up in the morning, rub their hands together, and say, how can I be mean to my healthcare provider today? Most people, I would say really every person, even demented people, have reasons for what they do. It's hard to understand those reasons. It's hard to agree with those reasons. It's hard to even recognize that there are reasons. But everyone has reasons for doing things. And so that's why it's so important to ask, why is someone being non-adherent? Well, here are a whole bunch of possible reasons why. One is forgetfulness. People, older adults in particular, just forget to do stuff. We don't have the executive function that we used to have, or we were never really organized to begin with. And so we don't take our medications. And particularly if a medication does not give an immediate and significant feedback, people will forget to take it. They will take pain medication because the pain medication makes them feel better. But if they're taking medication to lower their cholesterol, well, they can't see that. They can't see the cholesterol. And it takes several months for them to go back and have a blood test and for the doctor to give them a number, which has much more meaning for the physician than it does, or the nurse, than it does for the patient. So we forget. Sometimes people are concerned over adverse effects of the drugs. They don't feel good with other side effects over drugs. They don't really understand the purpose of the drug. Sometimes that's the reason that they'll sort of not have it high on their list of things to do. There are health literacy examples also. People don't understand what a therapeutic dose is. They don't understand the difference between a virus and a bacteria. So if they feel better after 2 days of an antibiotic, they won't necessarily take the rest of it because they think they're done and they'll put it in their medicine cabinet to save some money. There are a lot of economic factors. Many medications are expensive, and so patients will just cut the dose in half, take the pill every other day, literally cut the pills in half if they can in order to save money because, again, they don't understand the therapeutic dose. There are a lot of cultural factors about being sick, about taking medicines that get in the way. There are family and social factors. There's all this issue of resistance and confidence about doing regimens and sticking to care plans. And regimens themselves can have difficulty in administration. You have to take one medication in the morning and another one at night and another one at lunch, and sometimes it's a half a pill, and sometimes it's every other day. All of that stuff makes it just too hard to bother, particularly if the medications don't give them, or the care plan doesn't give them immediate feedback of being better. And then there's all the psychological factors of denial, vulnerability, reminder of chronicity. Every time they go to look at a pill, it reminds them of being sick, and so they don't want to be reminded, and so they won't take their pills. And then, of course, there's the cognitive factors of executive function and what happens with dementia that makes it even harder. So there are behavioral consequences of this compliance view. We know that there are increased adverse health events. The number of times patients end up back in the hospital for the same thing because they just haven't gotten a handle on it. Care plans are made, but they're not the focus of care. And so they're just words on a piece of paper. We get poor communication between provider and patient. And we have what I was doing with my dentist, which is called conciliatory resistance. Yesing them to death, but not following the recommendations when they get back home. And with that, older adults can start exhibiting aggressive behaviors with providers. My mother was a perfect example of that. She would fight with them all the time because she didn't agree with what they were saying. Or there would be just a lack of follow-through that the older adult would have. Or the older adult would go to multiple providers because they didn't like what a nurse or a physician was saying about something. And on the provider side, there's the equal lack of follow-up because they think their job is done by providing the gold standard recommendation. And it makes providers work in silos, and it does not foster the kind of teamwork that's really needed. And there are consequences for older adults, too. Again, in the compliance orientation, older adults will feel that they have no control. They will feel a tremendous increase in vulnerability, and they will once again do this conciliatory resistance as a way to get around all of that. But in the adherence orientation, they can maintain some autonomy if that's what they want, and they can have a feeling of control over the quality of their life. There will be enhanced communication with providers, and there will just be better medication management. So let's look a little more closely at from the provider side. In the compliance view, which is what providers have been taught to do in schools, there is an appearance of a power advantage, and there's an appearance of fulfillment of responsibility by imparting the gold standards, and there's an appearance of efficient care. But it's only appearance, because you need the adherence view to actually achieve the better outcomes and to have better communication with patients and families. It can't just be in one direction. And it allows a prevention on focus, a focus of prevention that was really not possible before. And a provider will just have much greater satisfaction in their practice because they will see better outcomes and they will see better caring. So increasing adherence, in order to increase adherence, you have to create behavior change on both sides, both for the patient and certainly for the provider. And so the provider has to determine why non-adherence is occurring. And you do that by simply asking the question, why? The provider needs to show empathy and a non-judgmental manner. There's nothing gained by judging the reason that someone is given you for being non-adherent. The reason is what it is, and the notion is to try to get around that and to lessen these barriers in a non-judgmental way. And so we need to discuss the concerns and readiness and the resistance and the confidence level of patients. And we need to simplify dosages and adapt regimens to lifestyles and concerns. It's particularly interesting when people are taking diuretics. They will have to go to the bathroom every 10 minutes, literally, or every 15 minutes. And so they won't take their medication if they're going out. But maybe if they take it in the evening at night, it would help them. So we have to see how their day goes and whether they can actually do what we are asking them to do. And if they can't do it, then what we're asking is totally useless. And we need education about diseases and medications, short education sessions, not lengthy ones for patients, and a lot of written materials as support documents. And we need reminder methods, and we need behavior modification. Everybody loves rewards. Everybody wants to be patted on the back for being recognized for doing good work. And so we really can have care plan contracts with patients where everyone agrees that a goal is doable and that everybody is ready and willing and able, in fact, to do it. So one acronym is just called AIDS in trying to improve medication adherence. You start with assessment that we talked about. You individualize a particular regimen based on people's on the patient's articulated concerns, and then we document it in a plan, and we educate patients, and then we supervise them and give them good coaching to get it done, and that helps along the way. And if we negotiate with a patient, we want to have sort of 6 steps to common ground. And so again, we identify all the needs and wants of all the participants, whether it's you, the patient, family members, anybody else who's a stakeholder in the healthcare of this particular patient. And again, it's done in a non-judgmental way. We validate everybody's needs and emotions because they are what they are. We then brainstorm for all kinds of options and solutions. Once I got my hygienist to think about a different kind of goal, she came up with a whole slew of options that, in fact, worked for me. And we negotiate for a consensus, we evaluate the patient's confidence and readiness, and we put a limited time frame on it. Everybody will try something for a little while because they know at the end of the time frame that they can still say no and that the plan will be reworked. So we agree on a plan and we agree on a time frame, and then we can evaluate the success or failure of that plan and move on to the next phase. So really, to kind of conclude this, there are a few things to remember. Resistance yields information. Resistance is not bad. Resistance is the best source of information that you have to provide good care to a patient. And again, gold standard protocols are only as good as their implementation. They are useless if the patients will not conform to them. So don't let the perfect get in the way of the good. And to understand that it's really hard for patients to be good. It takes a lot of control and focus for people to change their behaviors. And once again, the win-win is really best. So there are lots of things to remember here. And for the rest of your time related to this module, we hope that you'll develop your own case example. You can use my example of the dentist, but I'm sure you have many patients where the notion of compliance has not really worked well. And so think about the elements of an adherence focus and how you might relate differently to these patients. So first, please think of a patient where adherence to medical advice or a medical regimen has been difficult. Analyze the elements of a patient's situation according to the content of this module. For example, is there an adequate care plan? Does it have a definition of problems and goals and responsible parties and a time frame? Was there an overall assessment to create a baseline and identify problems? Can you think of a patient who may be exhibiting conciliatory resistance with you? What are some of the reasons you can think of that might contribute to the patient's non-adherence? Was there an assessment of a patient's preferences, skills, and confidence to participate in a plan? Can you think of providers who have a compliance rather than adherence approach to their patients? How might you enhance the adherence perspective in your practice? So we hope you will think about these things as you add this information from this module to your work environment and the way you approach your patients. So we have just some references here that we used in developing this module, references about care plans and references about adherence. And so I will say congratulations on the completion of this module. Thank you.